Okay, this recording is for the 33rd day of the Final Frontier NPTE prep course, March 11th, 2020, pulmonary examination and rehabilitation from the O'Sullivan text, and a little bit from the Therapy Ed 2018 text, chapter 14. So this is the book that Final Frontier uses. I use the 7th edition, they use the 6th edition, and so we are going to start with the reading.
Examination. The examination of the patient's pulmonary status has several purposes. 1. To evaluate the appropriateness of the patient's participation in a pulmonary rehabilitation program. 2. To determine the therapeutic interventions most appropriate for the participant's plan of care. POC. 3. To monitor the participant's physiological response to exercise. And 4. To appropriately progress the participant's POC over time. Patient history. A patient interview should begin with the chief complaint and the patient's perception of why pulmonary rehabilitation is being sought. The chief complaint is often shortness of breath and or loss of function. A medical history contains pertinent pulmonary symptoms specific to that patient: cough, sputum production, wheezing, and sob severity. Occupational, social, medication, smoking and family histories should also be obtained and documented. Laboratories. Tests. Various laboratory studies to examine patients with pulmonary disease may be performed and interpreted. These included radiology, pulmonary function tests, PFTs, including flow rates, arterial blood gas analysis, SAO2 measurements, and electrocardiograms, ECGs. Tests and measures vital signs HR, BP, aura, oxygen saturation, SAO2, temperature, and presence of pain, usually associated with shortness of breath, should be examined and documented. See Chapter 2, Examination of Vital Signs. An individual's height should be measured, as there is a direct relationship between height and lung volumes. Weight, for its use as a prognostic indicator, should be measured on a standard scale, and each subsequent measurement should be performed on the same scale. Observation, inspection, and palpation. By observing the neck and shoulders of a patient with pulmonary disease, the use of accessory muscles of ventilation can be observed. See Figure 12.6. A normal configuration of the thorax reveals a ratio of AP to lateral diameter of 1:2. Destruction of the lung parenchyma results in an increase of the AP diameter and a reduction of this ratio up to 1:1. See Figure 12.5. During inhalation and exhalation, both sides of the thorax should move symmetrically. Any asymmetry should be noted and documented. Cyanosis is a bluish discoloration of the skin that can be observed periorally, periorbitally, and in nail beds. It indicates acute tissue hypoxia. An indicator of more chronic tissue hypoxia is digital clubbing of the fingers and toes. In digital clubbing, there is an increase in the angle created by the distal phalanx and the point where the nail exits from the digit. The tip of the distal phalanx becomes bulbous. Fig 12.12. Auscultation of the lungs. Auscultation involves listening over the chest wall as air enters and exits the lungs. To perform auscultation of the lungs, a stethoscope is placed firmly on the patient's thorax anteriorly, laterally, and posteriorly. Figure 12.13. The patient is asked to inspire fully through an open mouth, then to exhale quietly. Inhalation and the beginning of exhalation normally produce a soft rustling sound. The end of exhalation is normally silent. This characteristic of a normal breath sound is termed vesicular. When a louder, more hollow, and echoing sound occupies a larger portion of the ventilatory cycle, the breath sounds are referred to as bronchial. When the breath sounds are very quiet and barely audible, they are termed decreased. These three terms, vesicular, bronchial, and decreased, allow the listener to describe the intensity of the breath sound. In addition to the description of the intensity, there may be additional sounds and vibrations heard during auscultation. These are called adventitious breath sounds. These sounds are superimposed on the already described intensity of the breath sound. According to the American College of Chest Physicians and the American Thoracic Society, there are two types of adventitious sounds: crackles and wheezes. 47 crackles, previously termed wails and ronchi, sound like the rustling of cellophane and have a multitude of potential causes: tissue fibrosis, secretions in the airways, pulmonary edema, and so forth. Wheezes have been described as high-pitched, coarse, whistling sounds. A decrease in the size of the lumen of the airway will create a wheezing sound, much like stretching the neck of an inflated balloon narrows the passageway through which air must escape, producing a whistling sound. Measurement of dyspnea and quality of life. There are many scales that can be used to quantify dyspnea, measured at the beginning and the end of a rehabilitation program and during periods of exacerbation can be accomplished using the clinically practical modified British Medical Council MMOC dyspnea scale. 48. The baseline dyspnea index, BDI, is another dyspnea scale that is encountered more in the research literature than in clinical practice. 49. While both these scores are reliable and valid, they are not interchangeable. 50. Quality of life, QOL, measures that are specific to chronic pulmonary dysfunction included the Chronic Respiratory Questionnaire and the St. George's Respiratory Questionnaire. 51. 52. Shorter disease-specific QOL measures such as the COPD assessment tests, CAT, and the COPD Control Questionnaire, CCQ, may be more clinically useful in determining the patient's baseline health-related quality of life. 53-55. These outcome measures may be helpful in demonstrating improvement made with physical therapy intervention. Table 12.3 presents information regarding these dyspnea and QOL outcomes measures. Measurement of strength and endurance. Patients with pulmonary disease may show peripheral and ventilatory muscle weakness due to their conditioning, malnutrition, steroid use, and the systemic inflammation of the disease process. 11. 56-58. Muscle weakness can contribute to exercise limitations and an inability to perform activities of daily living, ADL. Therefore, measurement of peripheral muscle strength and inspiratory muscle strength will determine the need for strength training during rehabilitation. The use of manual muscle testing, MMT, may not be the best choice for strength assessment. The maximal effort that is required during MMT makes it likely that patients will produce a Valsalva maneuver while performing the tests. In patients with pulmonary disease, the increased intrathoracic pressure from a Valsalva maneuver closes off the small airways, causing shortness of breath and therefore limits full participation in the tests. A 5x sit-to-stand test might be a better choice to assess functional lower extremity strength in patients with pulmonary disease. 59, 60 to 6. Minute pegboard and ring test is a measurement of upper extremity function that has been shown to be a reliable and valid measurement tool. 61. Inspiratory muscle strength is determined by measuring the patient's ability to create a negative inspiratory pressure, PMX. The standard starting patient position for the test is seated with nose clips in place. The person is asked to let out all their air before beginning the tests, i.e., start the test at residual volume. The person is then asked to breathe in against an occluded mouthpiece. The negative pressure is recorded using an aneroid manometer. 62. The result of this test is the negative pressure, reported in millimeters of mercury or centimeters of water, that was generated and sustained after 1 second of effort. 7. Normative values for inspiratory pressure are related to a person's characteristics of age and sex. 63. This ability to generate a negative inspiratory pressure reflects the strength of the muscles of inspiration. Exercise testing in patients with pulmonary disease and exercise tolerance tests, ET, can provide objective information to 1. Document a patient's functional abilities, 2. Document a patient's symptomatology, 3. Prescribe safe exercise, 4. Document changes in oxygenation during exercise and determine the need for supplemental oxygen, and 5. Identify any changes in pulmonary function during exercise performance. An ET protocol gradually increases exercise intensity in order to stress the patient with pulmonary dysfunction to their point of limitation. Incremental cyclodometry testing is widely used in clinical practice for patients with chronic pulmonary disorders. The American Thoracic Society and American College of Chest Physicians recommend a protocol that begins with 3 minutes of rests, 3 minutes of unloaded pedaling, and then an increase of 5 to 25 watts every minute until the patient reaches exhaustion. 64. Heart rate, blood pressure, ECG, respiratory rate, rate of perceived exertion, RPE, rate of perceived dyspnea PD, and oxygen saturation, SO2, are monitored during the tests. Documentation of peak nature, PEAK-PD, peak RPE, and peak workload can be used to appropriately prescribe exercise. Peak VO2 is also a measurement that can be collected during an ED but requires equipment not always found in the clinical setting. PFT is performed before and after an exercise test. Document the effects of exercise on lung function. A reduction of greater than or equal to 20% in FEV1 is an indication that exercise provoked airway hyperresponsiveness. 65 criteria for stopping a pulmonary AID are presented in box 12.2. The 6-minute walk test, 6MWT, is a functional performance measure that asks our patient to walk as far as possible in 6 minutes. The patient is allowed to stop and rest during the administration of the tests. Total distance walked is the recorded result of the tests. The 6MWT has been shown to have a good correlation with the patient's functional abilities. 66. The incremental shuttle walk tests, ISWT, is another functional performance measure that uses our recorded audio signal to dictate incrementally increasing walking speeds over level ground. 2 destination points are placed 9 meters apart, so that the walking path is 10 meters. The person is asked to reach each destination point by the time the increasingly frequent audio signal sounds. The test is terminated when the person can no longer keep up with the increasing tempo of the signals, meaning that the person is more than 0.5 meters from the cone at the time of the audio signal and cannot catch up during the next shuttle. Recording of SAO2, HA, and the PD occurs at the beginning and end of the tests. The results of the ISWT are the number of shuttles that the person completes. 67. These results have a positive correlation with maximal oxygen consumption. VO2 max 0.66 gate speed is an easy to perform outcome measure, needing only a stopwatch and a length of corridor. 68. Performing the test requires a 20-meter course. The acceleration leg of the course is the first 5 meters, the deceleration leg of the course is the last 5 meters, and the timed section of the course is the middle 10 meters. The person is asked to begin at the start of the 20-meter course and walk at a comfortable pace for the length of the course. The therapist measures the time it takes to traverse the middle 10 meters. The result of this outcome measure is gait velocity reported in either meter sec or feet sec. Data from these functional tests can be used to determine disability, predict hospital discharge disposition and mortality, assess the ability to perform ADL, quantify health-related quality of life, determine home and community walking abilities and the need for oxygen therapy, demonstrate the effectiveness of medication changes, and determine the prescription of exercise. 12, 65, 66. 68. Examining a patient's functional capability should be used as an outcome measure to document functional improvements following physical therapy intervention, even if an ECT has been performed. 6MWT is easy to administer and requires minimal equipment, making it the most commonly used outcome measurements to demonstrate changes in a patient's abilities following pulmonary rehabilitation. 69. The clinically significant change from a 6MWT is between 25 and 35 meters. 70. The clinically significant change for the ISWT is 47.5 meters. 71. The clinically significant change in gait speed is 0.05 meters second. 68. Table 12.4 presents information regarding these functional mobility outcomes measures. Exercise prescription. Exercise prescription for aerobic training incorporates 4 variables that together allow the therapist to develop a patient-specific exercise prescription designed to produce an increase in functional capacity. These variables are mode, intensity, duration, and frequency. Mode. Any type of sustained aerobic exercise can be used for pulmonary rehabilitation. Lower extremity lung activities, including walking and cycling, are often used to improve exercise tolerance. Specificity of training remains an important factor in the choice of exercise modes so that training translates into functional abilities. 72. Upper extremity, aerobic exercise, for example, arm ergometry, can also be included. Many programs utilize a circuit approach, combining a variety of resistive and aerobic exercises to train different muscle groups in different ways, with interspersed rest periods. Intensity. There are several ways to prescribe exercise intensity: oxygen consumption, HA, RPE, RPD, and the percent of peak workload. Below is a discussion of each means of prescribing exercise intensity. Exercise intensity as a percent of VO2 peak. Moderate intensity exercise can be prescribed using approximately 40% to 60% of the peak VO2 achieved on a net. Vigorous intensity exercise would be approximately 60% or greater of the peak VO2 achieved on a net. 73 patients with mild to moderate pulmonary disease may be able to exercise for a period of time at these intensities in order to produce a training effect. While using a percentage of VO2 may be the most accurate method of prescribing exercise from a graded exercise tests, assuming that peak VO2 is measured, it does not give the clinician a means to monitor exercise intensity during the actual performance during an exercise session. Exercise intensity as a percent of heart rate. There is a relationship between increasing workloads, increasing VO2, and increasing HR, making exercise HR a more practical choice for prescribing and monitoring exercise intensity in the clinical setting. 73 patients with mild to moderate pulmonary disease may not have a pulmonary limitation to their ability to perform exercise. Therefore, their exercise test may have the expected cardiovascular endpoint. If these patients have no other concomitant diseases, have no musculoskeletal or neurological constraints, and are committed to exercise, 70% to 85% of their highest age are achieved on the 8 could be used to prescribe exercise intensity. 73. It should be emphasized that when prescribing exercise intensity by HSHA, a heart rate range should be given, rather than a single number. Exercise intensity by rating of perceived exertion or rating of perceived dyspnea in patients with severe pulmonary impairments. Dyspnea may be the limiting factor to exercise performance. Patients with severe pulmonary impairment will likely approach their ventilatory maximum on an 8 before their cardiovascular maximum is reached. That is, their peak exercise HSHA may be lower than their maximum HR owing to pulmonary constraints. For these patients, prescribing exercise intensity using a percentage of the peak HSHA may underestimate their exercise abilities. The rating of perceived dyspnea obtained from an exercise test can be used to prescribe exercise intensity for patients with COPD. Table 12.5.74 77. A perceived dyspnea rating of up to 3, moderate SOP, corresponds approximately to 50% of VO2 max. A rating of about 5 to 6 corresponds to approximately 80% of VO2 max. The use of a PD, especially when levels of exercise are in the vigorous intensity range, 80% peak VO2, have been shown to be a valid and reliable means of prescribing exercise. 74. The APE is often used as a means of prescribing exercise intensity for patients with cardiovascular and pulmonary diseases. 73. 78. Using the APE scale allows the patient to self-regulate exercise intensity based on the perception of exertion. APE has been correlated with VO2, making it a useful means of prescribing and monitoring exercise intensity. Perceived exertion ratings of 12 to 13 and 14 to 17 on the 6 to 20 APE scale were correlated with 40% to 60% and 60% to 90% of VO2 max, respectively. 73. See additional discussion in Chapter 13, Heart Disease and Table 13.14. Exercise intensity as a percent of peak workload. Clinicians often prescribe exercise intensity by utilizing a combination of physiological parameters, for example, HSHA, RPE, and PD, as these measures allow for the day variations in a participant's physiological state. Using a percentage of peak workload, while not a physiological parameter, may be helpful when prescribing exercise intensity for patients with severe pulmonary disease. In this population, the exercise intensity needed to allow for a usual exercise session duration may be so low as to produce little or no training effect. 79. Exercise using short bursts of high-intensity activity, interspersed with low-intensity exercise or rest periods, that is, high-intensity interval training, HIIT, has been suggested. 81-89. According to the guidelines for pulmonary rehabilitation from the American College of Chest Physicians and the American Association of Cardiovascular and Pulmonary Rehabilitation, an exercise intensity that uses a high percentage of the patient's peak exercise capacity is well tolerated and physiological training effects have been documented. 90. There is a dose relationship between exercise intensity and training outcomes, meaning the higher the exercise intensity, the greater the training. 73. They do caution, however, that low-intensity exercise may be associated with better adherence. 90. Current research on interval training versus continuous exercise training is presented in Table 12.6. It may be the case that a 6 MWT is the only functional measurement available for a given patient. The 6-MWT has been determined to be a moderate to vigorous intensity for patients with pulmonary dysfunction, and the results can be used to predict peak VO2. 91-92. Therefore, the results of the 6-MWT can be used to prescribe exercise intensity. The common workload intensity associated with a 6-MWT is 80% of the average walking speed performed on the tests. 93. Duration exercising within prescribed exercise intensity for at least 20 to 30 minutes is recommended. 73. The duration of the training session varies according to patient tolerance, with some participants not being able to maintain continuous exercise for 20 to 30 minutes. Oscillating between high-intensity exercise and low-intensity or rest periods can be used to accomplish a total of 20 to 30 minutes of discontinuous exercise. Frequency. The frequency of exercise refers to the number of sessions performed on a weekly basis during the exercise training period. The frequency of exercise is often dependent on the intensity that can be achieved and the duration that can be maintained. If 20 to 30 minutes of continuous aerobic exercise can be accomplished using a moderate intensity, 3 to 5 evenly spaced workouts per week are recommended. More frequent exercise sessions are recommended for patients with lower functional abilities. 1 to 2 daily sessions are advisable for patients with very low functional work capacities. Pulmonary rehabilitation exercise training. A pulmonary rehabilitation exercise session includes the following components: check-in, warm-up, exercise at the prescribed intensity, and cool-down. The check-in period is a time to obtain baseline data, including resting HR, EP, oxygen saturation, auscultation of the lungs, and weight. It is also the time to discuss medication schedules, any problems the patient may have encountered since last visit, and any changes that need to be addressed by a member of the pulmonary rehabilitation team, such as a change in expiratory flow rates, cough, or sputum production. Pulmonary function tests assessed with a handheld device may be performed pre- and post-exercise during a pulmonary rehabilitation session to assess the impact of the maintenance medication. Patients who use a rescue inhaler should carry this with them during the exercise session. If a patient was found to have a significant decrease in oxygenation on their exercise tests, supplemental oxygen should be readied before initiation of physical activity. The warm-up component is a time to slowly increase the HRMPP to ready the cardiovascular, pulmonary, and musculoskeletal systems for aerobic exercise. For those patients with mild to moderate lung disease who had a cardiovascular endpoint to their exercise tests, the warm-up is usually accomplished by performing the same mode of exercise that will be used in the aerobic portion of the program, but at a lower intensity, with an emphasis on controlled breathing. For example, cycling with no resistance could be used as a warm-up activity for a biking program. The warm-up for patients performing continuous exercise lasts approximately 5 minutes. For patients with severe lung disease who are prescribed short bursts of high-intensity exercise, there is little opportunity for a warm-up. The exercise portion of the pulmonary rehabilitation session consists of a mode or modes of activity at the appropriate intensity for the advised duration. This portion of the program lasts for at least 20 minutes of either continuous or discontinuous activity. Participant monitoring can be accomplished using a P and a PD scales and measures of HR, and SAT2, oximetry. The training period should be followed immediately by a cool-down period consisting of a slow decline in exercise intensity after the patient completes the exercise duration. Prescribed. This may consist of 5 to 10 minutes of low-level activities that slowly return the cardiovascular system to near pre-exercise levels or ramping down of the intensity of short bouts of exercise. Finally, stretching exercises are performed to maintain joint and muscle integrity and to help prevent injury. Stretching exercises should be performed during exhalation to prevent a Valsalva maneuver, which would worsen a participant's pulmonary capabilities and put undue stress on the cardiac system. Patients often use accessory muscles of ventilation during the exercise program. Therefore, the muscles of the neck and US should be incorporated into the stretching program. Strength training. Extremity strength training while cardiopulmonary endurance training through continuous or discontinuous exercise is the mainstay of pulmonary rehabilitation. Generalized strength training has been found to counter the systemic effects of COPD that result in peripheral and ventilatory muscle weakness. Strength of both US and LES has been shown to increase with appropriate training. Weight training of the targeted muscle groups has been prescribed in a variety of ways. Von Bank et al. 94 improved work capacity by using a training load that allowed for 8 to 15 repetitions before fatigue. A number of strengthening methods have been used, including free weights, isokinetic devices, step climbing, high resistance on a cycle odometer, and Theradent 95, 96 regardless of the mode used for strengthening. Patients should be encouraged to perform these exercises during the exhalation phase of ventilation, thus refraining from a Valsalva maneuver that may impair ventilation and affect exercise performance. Inspiratory muscle training. Patients with COPD may have weak inspiratory muscles that translate into breathlessness and exercise limitations. 90. In the presence of inspiratory muscle weakness, defined as a PMX of less than 60 mm Hg. Many research studies have demonstrated the ability to increase inspiratory muscle strength using threshold loading devices. 97. 105 inspiratory muscle training devices provide resistance to the inspiratory phase of ventilation in order to increase the strength of these muscles. Figure 12.14 shows one type of inspiratory muscle training device. Philips Healthcare. Andover, MA. Inspiratory muscle training has also been studied for its ability to alter the perception of dyspnea. A number of researchers have demonstrated a decrease in the severity of dyspnea during the performance of ADL and exercise with inspiratory muscle training. 99,102,104. 105. The use of inspiratory muscle training should be made based on the patient's type of disease, severity of disease, presence of inspiratory muscle weakness, level of dyspnea, and motivation to participate. 90. Just as there are continuous versus interval training for the general exercise portion of pulmonary rehabilitation, these two options have also been reported for inspiratory muscle training. Continuous inspiratory muscle training uses a submaximal training load, as low as 10% of the patient's PMX for a prolonged duration of up to 20 to 30 minutes. Progression of this exercise prescription is to slowly increase the training load over time, upward to 60% of the initial IMAX. 97. Interval training uses a higher load, up to maximum load tolerable, for short bursts of 2 to 3 minutes of exercise interspersed rests of 1 to 2 minutes. 105. Both types of protocols have shown that improvements in respiratory muscle function and decreases in dyspnea. There is also literature that shows an increase in functional mobility with training of the inspiratory muscles. 105. Exercise progression. Exercise progression is appropriate when the individual perceives the exercise session to be easier, lower P or a PD, or when the same exercise workload is performed with a lower HR, that is, when physiological adaptation to exercise has occurred. Exercise progression should first be directed toward increasing the number of continuous minutes of exercise and decreasing the amount of time spent in low-intensity exercise or rest periods. When 20 minutes of continuous activity can be accomplished, an increase in exercise duration or intensity can be proposed. Frequency should be adjusted as necessary, based on duration and intensity. Program duration. Improved exercise tolerance can occur in multiple settings: an inpatient rehabilitation hospital program, an outpatient pulmonary rehabilitation program, or a home-based program. 3. Because of the limited length of stay for many inpatient rehabilitation hospital admissions, most increases in functional capacity occur in an outpatient or home pulmonary rehabilitation program. Generally, conditioning exercises are conducted up to 3 times per week over a course of 6 to 12 weeks. 90. At the end of the rehabilitation program, whole measurements, dyspnea measurements, and functional assessments, 6MWT or ISWT, should be re-administered to assess the benefits of pulmonary rehabilitation for each participant. Exercise abilities gained in the pulmonary rehabilitation program have been found to gradually decline over 12 to 18 months following completion of the program. Pulmonary rehabilitation programs that last longer than 12 weeks have shown greater sustained benefits than shorter programs. 90. An unfortunate reality is that patients with pulmonary dysfunction often have decreased exercise ability following an exacerbation of their disease. There is evidence to support a reduction in dyspnea in patients who repeat pulmonary rehabilitation after an acute exacerbation of their COPD. 106. Home exercise programs. A home exercise program, HEP, should begin while the participant is enrolled in a pulmonary rehabilitation program. When deemed appropriate, based on exercise response and laboratories data, the participant can be assigned home exercise activities. The patient uses an exercise log to record parameters such as exercise HRs, RPEs, RPD, exercise workloads, and any questions that may arise about the HEP. Figure 12.15. At regular intervals, the therapist analyzes the data and adjusts the HEP as necessary. Progression to an independent HEP is an important rehabilitation goal to promote a participant's lifelong commitment to exercise. P459 secretion removal techniques. Secretion retention can interfere with ventilation and the diffusion of oxygen and carbon dioxide in some patients with pulmonary disease. Patients with secretion retention may improve their exercise performance if proper secretion removal techniques have been performed before the physical activity. An individualized program for secretion removal directed to the areas of involvement can optimize ventilation and therefore gas exchange capabilities. Secretion removal techniques include programs that rely on a caregiver, postural drainage, percussion, and shaking, or independent programs, such as the active cycle of breathing technique, ACBT, positive expiratory pressure, PEP, devices, such as the TerraPEP registered sign, PEP therapy system, Smith's Medical, Dublin, Ohio, airway oscillation devices, such as the Flutter registered sign, Cardinal Health, Dublin, Ohio, or the Acapella registered sign, Smith's Medical, Dublin, Ohio, or high-frequency chest compression, HFCC, devices, such as the Vest registered sign, system, IROM, St. Paul, MM, manual secretion removal techniques, postural drainage positioning of patients so that the bronchus of the involved lung segment is purpose. P459 secretion removal techniques. Secretion retention can interfere with ventilation and the diffusion of oxygen and carbon dioxide in some patients with pulmonary disease. Patients with secretion retention may improve their exercise performance if proper secretion removal techniques have been performed before the physical activity. An individualized program for secretion removal directed to the areas of involvement can optimize ventilation and therefore gas exchange capabilities. Secretion removal techniques include programs that rely on a caregiver, postural drainage, percussion, and shaking, or independent programs, such as the active cycle of breathing technique, ACBT, positive expiratory pressure, PEP, devices, such as the TerraPEP registered sign, PEP therapy system, Smith's Medical, Dublin, Ohio, airway oscillation devices, such as the Flutter registered sign, Cardinal Health, Dublin, Ohio, or the Acapella registered sign, Smith's Medical, Dublin, Ohio, or high-frequency chest compression, HFCC, devices, such as the Vest registered sign, system, IROM, St. Paul, MM, manual secretion removal techniques, postural drainage positioning of patients so that the bronchus of the involved lung segment is perpendicular to the ground is the basis for postural drainage. Using gravity, these positions assist the mucociliary transport system in removing excessive secretions from the tracheobronchial tree. Standard postural drainage positions are presented in Figure 12.16. Although these postural drainage positions are optimal for gravity drainage of specific lung segments, such positioning may not be realistic for some patients. Modification of these standard positions may prevent any untoward effects yet still enhance secretion removal. Box 12.4 lists precautions that should be considered before instituting postural drainage with patients with signs and symptoms of increased daily pulmonary secretions. These are not absolute contraindications, but relative precautions. The list is not meant to be inclusive. However, it does provide a range of considerations that should be addressed before instituting postural drainage. Percussion. Percussion is a force rhythmically applied with the therapist's cupped hands to the patient's chest wall. The percussion technique is applied to specific areas on the thorax that corresponds to an underlying involved lung segments. The technique is typically administered for 3 to 5 minutes over each involved lung segment. Percussion is thought to release the pulmonary secretions from the wall of the airways and into the lumen of the airway. By coupling percussion with the appropriate postural drainage position for a specific lung segment, the probability of secretion removal is enhanced. Because percussion is a force directed to the thorax, there are conditions that would necessitate caution with this technique, such as a fractured rib, a flailed chest, osteoporosis, elevated coagulation studies, or a decreased platelet count. These examples are by no means inclusive. but they provide some patient presentations that might require modification, a gentler force applied to the thorax, or elimination of the percussion technique. Shaking following a deep inhalation, a bouncing maneuver is applied with the therapist's open hands to the ribcage throughout the expiratory phase of breathing. This shaking is applied to a specific area on the thorax that corresponds to the underlying involved lung segment. 5 to 7 deep breaths with shaking on exhalation are appropriate to hasten the removal of secretions via the mucociliary transport system. Shaking is commonly used following percussion in the appropriate postural drainage position. Because this technique consists of a force applied to the thorax, the same circulatory and musculoskeletal considerations are needed as in the application of percussion. Airway clearance once the secretions have been mobilized with postural drainage, percussion, and shaking. The task of removing the secretions from the airways is undertaken using an airway clearance technique. Coughing is the most common and easiest means of clearing the airway. However, it should be noted that high intrathoracic pressures, such as those generated during coughing, could force the closing of small airways in some patients with obstructive pulmonary diseases. By trapping air behind the closed airway, the forced expulsion of air during a cough becomes ineffective in clearing secretions. Puffing is an alternative method of airway clearance that is useful for patients with obstructive pulmonary disease. A huff uses many of the same steps of coughing, without creating the high intrathoracic pressures. The patient is asked to take a deep breath and then rapidly contract the abdominal muscles while forcefully saying ha-ha-ha-ha. This allows a forced expiration through a stabilized open airway and makes secretion removal more effective. 107. Active cycle of breathing techniques. ACBT is an independent breathing exercise program the patient can perform to clear secretions from the airways. This technique includes 3 phases. 1. A breathing control phase. 2. A thoracic expansion phase. And 3. A forced expiratory technique. ACBT begins with a few minutes of the breathing control phase, defined as relaxed, diaphragmatic, tidal volume breathing. From this breathing control phase, the patient determines what to do next. If secretions need to be loosened, the patient will perform 3 to 4 thoracic expansion exercises, defined as 3 to 5 deep inhalations with a 3-second hold followed by a passive exhalation. A return to the breathing control phase follows, which can last for a few seconds to a few minutes, while the patient assesses themselves and makes a decision of what is next needed. If the patient feels that there are secretions ready to be moved more proximally, then the forced expiratory technique completes the cycle. The forced expiratory technique, defined as 1 or 2 huffs from tidal volume down to low lung volumes, is used to move secretions into the larger, more proximal airways. The forced expiratory technique is followed by a period of breathing control for rest and reassessment. If secretions are not ready to be expelled, the patient may return to thoracic expansion exercises. Using ACBT, secretions are milked from smaller to larger airways. Once the secretions have moved into the larger airways, puffs from mid or high lung volumes remove the secretions from the airways. This independent technique has been demonstrated to be as effective as postural drainage, percussion, and shaking. 108. Figure 12.17 emphasizes that the patient begins at breathing control and always returns to breathing control for rest and the patient's own assessment of his or her status before moving to either thoracic expansion with breath hold or the forced expiratory technique. Oral airway oscillation devices. Airway oscillation devices, such as the flutter registered sign or the a cappella registered sign, figure 12.18, alter the exhaled airflow throughout the airways. The patient first inhales a normal-sized breath. During active exhalation through the device, the exhaled air causes an intermittent backward air pressure that oscillates the airways. The usual procedure is to exhale 10 or so breaths through the device, followed by 2 large exhale volumes through the device and finally a huff or cough to clear mobilized secretions. This routine is repeated until secretions are cleared from the lungs. An airway oscillation device has been shown to help in the removal of secretions from airways. 109,110 positive expiratory pressure PEP devices have a valve to regulate expiratory resistance. Figure 12.19. Inhalation of a normal-sized breath through the mask or mouthpiece is unresisted. Active exhalation is against a positive expiratory pressure, measuring 10 to 20 centimeters H-low. A treatment session lasts approximately 10 to 20 minutes with frequent pauses to remove the mask or mouthpiece so that the patient can cough or huff to clear secretions. session is completed when all secretions have been cleared from the airways. PEP has been shown to be as effective as postural drainage, percussion, and shaking. 111,112 high-frequency chest compression devices. The high-frequency chest compression (HFCC) device uses an inflatable vest with air channels that is worn over the patient's thorax. Figure 12.20. The vest is attached to an air compressor that rapidly delivers small air volumes in and out of the vest. The inflation of the vest causes compression to the chest wall, and the deflation allows the chest wall to recoil back to its resting position. The patient assumes a comfortable seated position for treatments lasting between 20 and 30 minutes. Secretions may be cleared at any time throughout the treatment. HFCC has been shown to be as effective as other secretion removal techniques. 113 breathing exercises. Pursed lip breathing involves an unresisted inspiration followed by an active oral exhalation through a narrowed or pursed mouth opening. When pursed lip breathing is used by patients with COPD, it may delay or prevent airway collapse, allowing for better gas exchange. 115. Most patients demonstrate this strategy during periods of dyspnea and rarely need to be taught the technique. Although diaphragmatic breathing has been taught to patients with chronic pulmonary dysfunction for years, there is little evidence to support its use to improve pulmonary mechanics. 115. Some patients require the use of accessory muscles with exercise, with exacerbation of their disease, or with periods of dyspnea. Strengthening accessory muscles of ventilation may be a more effective treatment program than encouraging the use of an ineffective diaphragm with little ability to generate muscle force nor limited muscle exertion. In patients with very flattened diaphragms, focusing on diaphragmatic breathing may even be detrimental. Activity pacing. Activity pacing refers to the performance of any activity within the limits or boundaries of that patient's breathing capacity. For example, an activity that usually causes dyspnea needs to be broken down into component parts such that each component can be performed at a rate that does not exceed breathing abilities. By breaking activities down into component parts and interspersing rest periods between each component, the total activity can be completed without dyspnea or undue fatigue. For example, patients often find that climbing stairs causes a great deal of dyspnea and discomfort. Rather than climbing the entire flight of stairs, usually done too fast and with a breath hold, the patient might be instructed as follows: take a deep breath. Now, on exhalation, walk up 1 or 2 or 3 stairs. Now recover. Take in another good breath and walk up the next 1 or 2 or 3 stairs and recover. Repeat this technique until the flight of stairs is completed. The patient is able to reach the top of the stairs without becoming dyspneic and without undue fatigue. Pacing can be part of every activity that would otherwise cause dyspnea. Pacing should be used when performing ADL, ambulation, stair climbing, and other daily tasks. Pacing is not a technique to be used during the aerobic portion of the pulmonary rehabilitation program. During exercise, some shortness of breath is expected to occur. O'Sullivan, Susan B. Schmitz, Thomas J. Full.
Okay, so that is the conclusion of the reading. And let's see. Some of the tables that the reading talked about was table 12.3, outcome measures, dyspnea, and quality of life. Box 12.1, examples of goals and outcomes for patients with chronic pulmonary dysfunction. Patient, client, family, and caregiver understanding of disease process, expectations, goals, and outcomes is enhanced. Cardiovascular endurance is increased. Strength, power, and endurance of peripheral muscles are increased. Performance of physical tasks, both basic activities of daily living and instrumental activities of daily living, is improved. Strength, power, and endurance of ventilator muscles is increased. Independence and airway clearance is improved. Patient-client decision-making ability regarding the use of healthcare resources is improved. Patient-client self-management of symptoms and self-management of pulmonary disease are enhanced. Figure 12.12, the digital tubing is a sign of chronic tissue hypoxia. A shows a normal nail, B shows early clubbing, with angle present between nail and proximal skin, and C shows advanced clubbing. Figure 12.13, oscillation of the lungs. A global assessment of lung sounds requires the therapist listens through a stethoscope, which is placed anteriorly, posteriorly, and laterally on the upper, middle, and lower thorax. Okay, so for a second. Okay, so I went and pulled some information from the book that we just heard in the reading. Auscultation involves listening over the chest wall as air enters and exits the lungs. To perform auscultation of the lungs, a stethoscope is placed firmly on the patient's thorax anteriorly, laterally, and posteriorly. So you can see in the figure 12.13, right below the clavicle, and then right at 1, 2, 3, 4, 5, just under the 5th rib and right under the 6th rib. So that's the 5th rib and the 6th rib. And then on the back you have right above the spine of the scapula. Okay, so we're at what? Okay, and then again, where is that? 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6. 6. And then again below the scapula, right below the scapula. So 1, 2, 3, 4, 5, 6, 7, 8. The patient is asked to inspire, to breathe in fully through an open mouth, then to exhale quietly. That's interesting. Patient is asked to inspire fully through an open mouth. I don't remember knowing an open mouth. Interesting. And then to exhale quietly. Inhalation and the beginning of exhalation normally produce a soft rustling sound. The end of exhalation is normally silent. This characteristic of a normal breath sound is termed vesicular. When a louder, more hollow and echoing sound occupies a larger portion of the ventilatory cycle, the breath sounds are referred to as bronchial. When the breath sounds are quiet, very quiet and barely audible, they are termed as decreased. These three terms, vesicular, bronchial, and decreased, allow the listener to describe the intensity of the breath sound. Okay? That intensity of the breath sound. In addition to the description of the intensity, there may be additional sounds and vibrations heard during auscultation. These are called adventitious breath sounds. These sounds are superimposed on the already described intensity of the breath sound. According to American College of Chest Physicians and the American Thoracic Society, there are two types of adventitious sounds. adventitious sounds, which are crackles and wheezes. Crackles, previously termed rails or ronchi, sound like the rustling of cellophane and have a multitude of potential causes, such as tissue fibrosis, secretions in the airways, pulmonary edema, and so forth. Wheezes have been described as high-pitched, coarse, whistling sounds. A decrease in the size of the lumen of the airway will create a wheezing sound, much like stretching the neck of an inflated balloon narrows the passageway through which air must escape, producing a whistling sound. Very interesting. So, two adventitious sounds, which are crackles and wheezes. Okay. Box 12.2, graded exercise test termination criteria. Number 1, maximal shortness of breath. 2, a fall in PaO2 of greater than 20 or a PaO2 less than 55. A rise in PaCO2 greater than 10 or greater than 65. Cardiac ischemia or arrhythmias. Systems of fatigue. An increase in diastolic blood pressure readings of 20. Systolic hypertension greater than 250. Decrease in blood pressure with increasing workloads. An increase in diastolic blood pressure readings of 20. Diastolic blood pressure goes up 20. The bottom number. The pressure in your heart when your heart relaxes goes up 20. Systolic hypertension greater than 250. That's the top number. That's pretty high, 250. A decrease in blood pressure with increasing workloads. So the harder they work, the lower their blood pressure goes. Leg pain, total fatigue, signs of insufficient cardiac output, and reaching a ventilatory maximum. And here's a table of ratings of perceived exertion, a Borg CR10 scale, 0, nothing at all. Let's see, 0.5, extremely weak, just noticeable. 2 is weak, light. A 5 is strong, heavy. A 10 is extremely strong. And a 12 is absolute maximum highest possible. Precautions for postural drainage. Precautions for the use of the Trendelenburg position. Circulatory, congestive heart failure, and hypertension. Pulmonary. Pulmonary edema, shortness of breath made worse with Trendelenburg position. Head of bed lower than foot. Abdominal, obesity, abdominal distension, hiatal hernia, nausea, recent food consumption. Precautions for the use of the side lying position, vascular, axillofemoral bypass graft, musculoskeletal, arthritis, recent rib fracture, shoulder bursitis, or tendinitis. Any conditioning that would make appropriate postural drainage positioning uncomfortable. Figure 1217. Active cycle of breathing begins with breathing control. All choices are made from the breathing control phase. After each choice is made, thoracic expansion or forced expiratory technique, the patient returns to breathing control to rest and make the next choice. Don't totally understand that one. And here are the postural positions used for postural drainage. And I go into this a little bit more in depth, so we're going to stop and make a part 2. Yep. We can give that its own little slide here. Okay. All right, so let's go ahead and stop this at an hour, and then we will do part 2 on the positions for postural drainage. Yep, that's what we're going to do.